Dear Pure Urology viewers, good evening one and all. Today, as part of the Pure Urology, we are discussing about the RIRS, how RIRS is commonly done worldwide now. So many advances have come in the scopes, access sheath, flexible suction access sheaths, digital scopes, but every case is different from other case. Sometimes you think that it is easy, it may become difficult. You may not see the stone. Stone may go into different calyx. These are various problems will be there. To discuss for that, one of my close friend from Egypt, very active in academic sessions, in the Pure Urology also, as well as in the social media, as well as Professor Mohamed Elshazly, who is MSc Urology and MD Urology. I will briefly introduce about him, and then so today topic is optimizing outcomes in RIRS, tips for complex cases. Professor Mohamed Elshazly from Egypt. He is a professor and a chairman of Urology Department, Menofia University, Egypt, Director Board Member, Egyptian Urology Association, completed Laparoscopic Urology Fellowship at North Hampshire Hospital, United Kingdom, former consultant urologist, Farvania Hospital, Kuwait, and tutor of Urology, Kuwait University, editorial board member, reviewer for several leading international urology journals, author of 35 plus peer-reviewed publications in high-impact international journals, including BJU International, World Journal of Urology, Urologia Internationalis, and Arab Journal of Urology. Recipient of multiple international awards for scientific video presentations and research in minimally invasive urology. Invited faculty and speaker at numerous international urology conferences, workshops, and training programs worldwide. As I mentioned, is active researcher, postgraduate teacher, and thesis supervisor with extensive contributions to education, endourology, and minimally invasive urological surgery. International recognized expert in endourology, PCN urolithiasis, laparoscopy, and reconstructive urology. I must say that in Egypt, a lot of the academics happen. Their annual conferences are of high standard. I have been to Egypt. With this introduction, I thank Professor Mohamed Elshazly for accepting the invitation, and I will hand over the program to you, sir. Don't worry about the time. It will be a permanent record. You give whatever insights so that the juniors will learn and do best to the patient. Thank you.
Thank you very much, my friend, Dr. Chandra. I'd like to sincerely thank you for this kind invitation to deliver this lecture. It is a privilege and honor to be a part of your Pure Urology platform since it started. This is my third lecture. I gave 2 lectures in BCNL, and this is my first lecture in retrograde interior surgery, and I am posting my experience regularly. I'd like to congratulate you on establishment of such a great platform, which become an outstanding initiative for sharing knowledge, exchanging experience, promoting continuous learning among urologists. Here in Egypt, many juniors are following the Pure Urology platform regularly, and very happy with the material you presented with experts all over the world. This great effort, I would congratulate you on this great effort.
Thank you.
My topic today will be on retrograde interior surgery. Before I start sharing my slides, originally, I am a PCNL surgeon. That's my favorable procedures. It is still the standard of care. Not to understand my lecture, I am against PCNL. No, I am originally a PCNL surgeon. Still, PCNL is the standard treatment for large staghorn stones or for large sizable stones. However, as scientists and the consultant, we should accept advancement in techniques and the evolution of all the endourological procedures. Despite our ego of having a great experience in one procedure that but maybe with time we change our mind. If it is more safe and better results for the patient, we should not stick with our favorable procedure, and we can accept the evolution and advancement in techniques. This is before I starting my slide. I prefer to see this introduction, and I think my slide is okay now. It's clear.
Yes, sir. Yes, yes, visible and audible clearly.
Okay, so I'll give my experience in the last few years in retrograde intrarenal surgery in optimizing the outcome and tips for complex cases. Flexible ureteroscopy has advanced considerably to become a widely utilized therapeutic tool for treatment of upper urinary tract stones. All of us know the place of retrograde intrarenal surgery in guidelines. Still, it is for small and mid-size stones only. Still, it is not for large branching stone, either in the upper ureter, kidney, or lower calyceal stones. So it is still BCNL, as I just said, is the standard for the large stones, but advancement in endoscopic technologies and operative techniques have led to broader application of flexible ureteroscopy in the management of urolithiasis to include larger and more complex stones. In the last guidelines, start retrograde intrarenal surgery to have a place in large stones if BCNL is not an option, or if it is not safe or patient choice not to have risk. Now, there is a place in the guidelines to work for large stones as a plan B if BCNL is not a safe option. However, the main challenges and the criticism of retrograde intrarenal surgery in comparison with BCNL is the less stone clearance. I mean the residual fragments and the need to do auxiliary procedure. The second challenge is sepsis, especially if worked for a long time with large stone will have a high risk of infectious complication. And the third concern is the ureteric injuries and late stricture if I work for a long time on larger stones. How to overcome these challenges? The residual fragment with multiple procedures. If we look for the evidence in literature, before 2020, the literature and the meta-analysis all stated that BCNL has a superior stone clearance, and in order to achieve head-to-head or stone-free rate between RIRS and BCNL, we need to do more than one procedure or staged procedure to achieve stone clearance. Regarding sepsis, in the guidelines, there is a possibility up to 5% of having infectious complication after retrograde intrarenal surgery, mainly due to high intrarenal pressure. You know, if the intrarenal pressure raises more than 25, we'll start to have backflow. If we increase vigorously more than 90, we may have fornix rupture and the high possibility of infectious complication, especially with prolonged operative time. So how to overcome these two problems, the less stone clearance and the more sepsis? Necessity is the mother of invention. In the last 5 years, we have a lot of advancement, mainly in having better disintegration by better laser machines, introduction of the new kit, the TFL or superpulsed thulium, with known more absorption, water absorption power, ability to increase frequency to 2200 or practically less than this. All this lead to high disintegration power. Low peak power can enable us to achieve small dust or true dust less than 250 micron. And this will lead to less disintegration time and better results. Also, the introduction of high power laser also improve the disintegration time. The recently introduced magneto hybrid YAG laser with a new possibility due to new pulse modulation. It can have a low peak power like TFL and extra long pulse, and it can achieve excellent result. This video, courtesy from Traxer, can show you how magneto can give excellent result in a difficult stone like cystine stone in this video. The other advancement after laser disintegration advancement is the suction. Suction introduced in the last few years either by direct in-scope suction within the working channel of the scope itself, or through using what's called flexible and navigable sheath introduced around 4 years back. The concept of suction is really a game changer, and adding many advantage evolution from the traditional axis sheath to the flexible axis sheath that can navigate and reach the target calyx and clear the dust or the small fragment. And recently, the continuous intrarenal pressure monitoring and automated units that can control the rate of irrigation, control the rate of suction, and maintain the target intrarenal pressure to a safe intrarenal pressure. This is really introducing a great add to retrograde intrarenal surgery. And personally, I start to move to larger stones after using of this suction maneuver, simply because I use continuous suction. I like fans more than this for some reason, because it gives me ability to have a continuous intrarenal suction that maintain a very minimal intrarenal pressure. Consequently, the infectious complication and the fever in my patients decreased dramatically after using the continuous intrarenal suction using fans. So the suction is a really game changer. A lot of publication, as you know, in the last few years, it can achieve the trifecta, or could achieve the trifecta. It is known, it is less invasive than BCNL, less morbid after decreasing the sepsis. And the good news is it enables to achieve a high stone-free rate, either by complete dusting, if I have a super duster machine like TFL or high power holmium, or even if I have low power holmium and only I did popcorning and achieved a multiple small fragment, I can, through the fans, I can retrieve this multiple fragment at the end of procedure and achieve a comparable result to complete dusting. So trifecta is nearly achieved with the using of suction, with minimizing the intrarenal pressure and decreasing the infectious complication. If you look at the literature, after 2020, in the last few years, the result now is different. A lot of publication showing excellent stone-free rate comparable to BCNL, especially in medium-sized stones. I was honored to be a part of the multi-national, multi-institutional research group pioneered by Vinny Gohar and the group of European section, and the Dr. Chandra Shiras, some of these articles, and we published many papers about the use of suction and the use of fans regarding efficacy and the safety, and it is a really promising step. And we can see what is on the ground. What is the pattern now? All of us know that shockwave is already decreasing. Maybe patient preference, higher stone-free rate by the retrograde intrarenal surgery. The notorious results or bad reputation by shockwave in some centers, abusing shockwave by disintegrating large stones. All of this and social media, all of this push the flexible ureteroscopy or retrograde intrarenal surgery more than shockwave. And in the last 2 years, maybe start to compete with the BCNL for medium size and large stones. So our world is now, in the urology world, is moving toward more RIRS and less puncture. Our guru Traxer is usually posting controversial tweets about the BCNL is decreasing, and many centers, yes, and yes, it's still controversial issue. BCNL surgeon is not happy with this post, but in Western countries mainly, and in countries where they don't have a complex stones like India, Pakistan, Egypt, these Western countries with small-sized stones where financial problem is not an issue, they move rapidly toward flexible ureteroscopy. In our stone-built areas, as India, Pakistan, and Egypt, and Middle East, mostly still were lagging, were still BCNL financially and cost effective is the best for the large stones, but many centers now moving toward more flexible ureteroscopy. This is introduction to my lecture, and my lecture will cover some difficult situation like complex anatomy, like large stone burden, technical challenges during retrograde intrarenal surgery, how RIRS has a great focused approach and reach remote areas in the kidney, some challenging scenarios in retrograde intrauterine surgery, and troubleshooting, how to overcome the troubleshooting and nightmares. Firstly, regarding the complex anatomy, the most famous anatomical anomalies we face is the horseshoe kidney and ectopic kidney. The main concern of horseshoe kidney is two concerns. That mainly the ureter in horseshoe kidney is not usually a friendly ureter. You know, it is like vase appearance, stretched from downward, upward, and cannot be negotiated easily. And in many situations, I prefer to do a staged procedure in both ectopic kidney and horseshoe kidney to put a stent and come back after 2 weeks, at least 2 to 4 weeks. 2 weeks is enough mostly in most of the patient. And I use the fans or access sheaths, or if it is not friendly much, I use backloading and this. But the step of stenting in horseshoe and ectopic kidney, I advise you to do it, and it will help too much in the second stage to work in a friendly ureter without problems. The second point in horseshoe kidney and ectopic kidney is the abnormal pelvic cell system. So I prefer you should be clear in counseling and not promise your patient that you will clear all the stone 100%, simply because some calyces are not reachable. You look at this pelvic cell system, for example, some lower calyx, sometimes it is more medial in the isthmus, in the start, in the isthmus. And if you do active deflection of your flexible scope and passive deflection maximally, even you cannot reach such difficult calyx, especially the one in the isthmus. This is very important in counseling, that some stones may be not reachable. Still, for large stones, I do PCNL for my horseshoe kidney patient, upper calyceal puncture, mostly avoid middle and lower. But some patient concerned with the risk of PCNL, like this case, I told them if it is large stone, may take 2 sessions, and patient agree and accepted to have this result, not to have PCNL. But still, for large stones, PCNL is the first option in horseshoe kidney. For ectopic kidney, the same. Better to put stent, and some calyces are difficult to reach. I should tell my patient that. And you can see here how the scope suffer in deflection in difficult angle, scope damaged in this case. I used 2 scopes in this case. So sometimes the calyces is very challenging. I need aggressive deflection to reach the difficult sites of stone, but fortunately it was clear at the end of the procedure. And this is another ectopic kidney case done last month. The patient was a very difficult patient, as he has a hip fixation on his right hip, very difficult position, hardly could see or negotiate the right ureteric orifice, put a stent, and after 2 weeks, hardly negotiate the orifice, and clear the stones using the retrograde intrauterine surgery. If you look at this patient, what is the alternative? All the alternative difficult. If you'll do PCNL for this case, it has an incisional hernia of previous open surgery, and RIRS can save difficult situation like this case. Another option for the anatomical problem is the multiple calyceal stones. To avoid the multiple tract, PCNL is a strong addition to the armamentarium of urology to have what's called endoscopic combined intrarenal surgery. Rare surgeons now do multiple tract PCNL. You know, the multiple tract carry more morbidity, more bleeding, and more infectious complication. So in this situation, the retrograde intrauterine surgery can save having a multiple tract, and it can be combined with the supine PCNL. It is a fantastic approach, but sometimes it's challenging to have 2 towers and 2 teams in a busy list as our universities. The lower calyx, sometimes the infundibulopelvic angle is very acute. Manipulating the lower calyx in some situation is very difficult, but you can use a good urethral access sheath that can be bendable to the lower calyx, as in this case. If you have a good quality, it can be bent, and you can manipulate the case and either relocate the stone or firing on deflection according to the situation and according to the angle, as I said. One more anatomical problem, famous anatomical problem, usually we do debates in conferences about calyceal diverticular stones, symptomatic calyceal diverticular stones. Firstly, how to expect that the case has calyceal diverticulum, because most of the endourologists depend mainly on spiral or non-contrast CT. So in non-contrast CT, if you see a stone or multiple stone very peripheral near the outer surface of the kidney, you expect in a dilated calyx, you expect this may be stones in calyceal diverticulum. You can do contrast to confirm preoperative, or if you can manage after retrograde biography, you will confirm and you manage. In start of my career, usually we do PCNL was a fantastic option to puncture the diverticulum, as in this case, clear the stones, and after that we inject methylene blue to identify the narrow ostium, and after that we dilate the ostium either by telescopic dilators or laser in some cases, and put a stent, put a nephrostomy through this ostium for a few days, and it works well regarding BCNL. But in the last few years, I started to change my decision to why not to try retrograde intrarenal surgery in such cases. It is a bit difficult. Sometimes you couldn't identify the ostium. If you are lucky to identify the ostium like these cases, you pass guide wire and start to dilate the ostium with small bursts of laser firing. Usually you are afraid to have bleeding, but with small bursts in different direction we can go, and mostly it is safe in most of the situation. We don't have significant bleeding, and after we dilate the ostium, we go inside the diverticulum and clear the stones. Some, if you don't see the ostium, described by Traxel to do what's called methylene blue wash test, to inject methylene blue and wait for a few minutes. The methylene blue will go to the diverticulum and come back, and you can see the ostium in some situation. So it is an alternative. We don't have evidence in literature which is better. You do what you master, and still it is in some cases BCNL is easier, especially if the large stone burden, and if the position of the diverticulum is accessible to the BCNL, not very anterior. But in situation where the position of the diverticulum is difficult for BCNL, retrograde intrarenal surgery is an excellent plan B or alternative to BCNL in such situation. Another everyday situation that we face and suffer a lot is the complex lower calyx. Sometimes the lower calyx is very complex, and you do active deflection, maximum active deflection and the maximum passive deflection, and still in the corner you can see part of the stone, and the lateral position calyx you couldn't negotiate, or you couldn't get inside that lateral calyx simply because we don't have two active deflection scopes. We just have one active and one passive deflection. This is a problem. Reviewing literature, I found that SMI company created this two active deflection scope, and was reusable scope, 170 or 180 degrees deflection, and after that you can do another active deflection 130 degrees. I don't know why it was not popular, and I think the companies with single-use scopes, if they can achieve a scope like this, will be great to help negotiating difficult location or complex calyces, like the complex lower calyceal stones or anomalous kidney, for example. To target or to reach these difficult calyces, some companies introduced what's called steerable dormia. This steerable dormia, you can direct the tip of the dormia to the laterally position or the acute angle calyx, and you can reach the stone and remove it. What we do some ticks. We sometimes change the patient side. We tap on the, do some percussion. We do flushing. Sometimes we stop irrigation, because if you do irrigation, the stone will hide. And sometimes we do what's called stone fishing. Stone fishing to try blindly to send the dormia to this difficult site and catch the stone. And it works in many situations. Now we move to another difficult situation where patient coming with multiple bilateral renal stones like this. Imagine if you try PCNL for such situation, it will be it will need multiple session, multiple puncture. But for cases like this, you feel what's called RIRS was invented for such cases. You can finish such a difficult situation in a short time bilaterally in the same time. In this case, for example, the patient went to do CT by himself and he came back and I was happy with the result. Another case I did bilateral retrograde intrarenal surgery in a single session. And we published with the European section group, we published the utility to do bilateral same session flexible ureteroscope. But simply we should stick with the rules not to operate for a long time. I personally prefer not to exceed 60 to 90 minutes in retrograde intrarenal surgery. If the stone is larger, I counsel my patient for staged procedure, not to have long procedure. But you should consider other factors like morbidity of the patient, age of the patient, stone infected or not. You use flexible and navigable access sheaths and continuous suction. If I use continuous suction, I can operate for longer time. But if I use backloading and without sheaths, or I use interrupted suction with this, I don't prefer to exceed more than 60 minutes. So it needs judgment according to stone factor and patient factor, how long you operate, but better not to operate for a long time to avoid complications. Another point is the focused approach. The focused approach, the beauty of urology, we reached places we never reached before. You can, like sniper, attack the Randall's plaque, which is one of the theories of stone formation. It's simply, all of us know that it is a basement membrane, a calcification in the basement membrane of ascending lobe of Henle, and they can predispose to stones, especially calcium oxalate monohydrate. And in many patients, you can navigate the calyces and find many of this Randall's plaque, and you can navigate the calyces and remove all of this as a curative and prophylactic, not to have a larger, not to have stones after that. And it is a fantastic approach, not reached easily by other alternatives like open surgery or PCNL surgery. This is a beauty of retrograde intrarenal surgery that help us to understand the anatomy and the theory of stone formation like this. This is a controversial case. Many object about it. I don't advise young urologists to do it. Sometimes you go inside, the stone is seen by fluoroscopy, but no stone in the pelvic system. That's called papillary stone. Papillary stone, it is embedded in the papillae. Should we interfere? Mostly no benefit to interfere because the stone is not obstructed, mostly, but I couldn't resist the temptation to go in this case, to do simple small bursts until I reach the stone and remove the stones. Sometimes it can be multiple. It is some sort of tubular ectasia or mild form of medullary sponge kidney to have multiple buried stones inside the papillae. It is controversial. I prefer not to open the papillae by laser, despite if we do transpapillary puncture by 30 French nephroscope, we are happy, we are anatomical, and the possibility of bleeding is less than 8% because we are anatomical. But still, we don't have the confidence to play with laser in the papillae. Better, especially for the young urologist, to avoid this. But it is again a fantastic approach that the retrograde intrarenal surgery enable us to reach these very difficult situations. How retrograde intrarenal surgery can save challenging scenarios or difficult scenarios, like a savior that can save difficult or complicated cases. Again, as I said, it is an option where PCNL is risky. We can offer this for the patient. For example, this case was an upper polar stone around 2 centimeters. The kidney is very high, the liver is closed. I counseled my patient, I can do PCNL, but the puncture is risky. Or alternatively, I can do staged flexi. He is happy with the staged flexi. I inserted the stent 2 weeks. I went later and could reach the stone and finish it in the second session. So it gives us, with the patient counseling, alternative especially in risky cases if the patient is not happy to take the risk in difficult puncture. The same, this was a boy with the lower calcial sizable stone. The colon is very close, as you see in the left side, retrorenal colon. Still PCNL is feasible. We can go ultrasonic puncture, we can go very medially through the muscle. It is feasible, but the patient again refused to have a risk and prefer to have a staged procedure, insert stent, and to go back after 2 weeks again, and could reach the stone, but the angle was very difficult. I damaged the scope. I used 2 scopes in this case, but finally, in a difficult case, I cleared the stone more than 4 years now. I was happy and no stone recurrence. In some situation where wrong decision was taken, as in this case, refer to me after shockwave for large stones. The patient came with Cystine stress. Challenging case, took a long time. Semi-rigid finished some of the stones. After that, the flexible ureteroscopy completed the job and finished the rest of the Cystine stress fragment and declared the case in 1 session. It was very challenging, a lot of sizable fragment. The ureter was, as you see here, was a lot of fragment, the ureter inflamed, but fortunately it went well and cleared all the stone, helped by the retrograde intrarenal surgery. Another bad decision to have a shockwave in a large stones. You can see here the stone burden, large, and you can see the amount of residual after shockwave. Here we can do either multiple puncture PCNL, or we can clear, inserting the fans. All these fragments were cleared in a single session in around 1.5 hours. So it can save a difficult scenario or wrong decision like this. Another situation that multiple stones after PCNL. In the staghorn stones, sometimes you have like this multiple scattered stones. If you do again PCNL, you will need to do multiple puncture. I think this is a great job in retrograde intrarenal surgery, especially patient referred with a stent already inserted. After 1 month, I inserted the fans and declared all the stones in all calyces in a single session, like this case. Another case, similar case, multiple stones post-PCNL, referred to me again. I used the stent to insert an access sheath fans and declare all of the stone in a single session. The alternative would be multiple puncture PCNL, mostly, or endoscopic combined in this situation. But the fans clear the stones in a single session, saving this difficult situation. This is an interesting case. Was my first case to use the 6.3 scope of huge mid. It was a boy referred to me after 2 sessions of flexible ureteroscopy. The decision from the start was, I think, was not appropriate, the best to do mini PERC for this case, but they prefer to do retrograde intrarenal surgery. And after the second session of retrograde, multiple stones in the lower calyx, as you see here, and 1 stone in the upper calyx. And still he is refusing PCNL because he has already started the flexible. I used this 6.3. The angle to the lower calyx was very difficult. It was maximum active, maximum passive. I could reach the lower calyx and declare the stone in 1 session. And the stone was Cystine stones. And it was screening the family of this child. There was another family members having cystinuria, and they start to put him on prophylaxis, and he's doing well. 6 months now, no recurrence, and going on alkalinization and hydration therapy. Now we come to the situation, the medium-sized, the situation that put us in which technique to use, either to do PCNL or to do retrograde intrarenal surgery. I advise some of you to start what's called double counseling. I mean, if I have the facility to do both retrograde intrarenal surgery and PCNL, patient is happy with both, I'm telling my patient I'll go. If the ureter is friendly and it's okay, I'll go with retrograde. If the ureter is tight, need staged, I'll go for PCNL. And I do retrograde intrauterine surgery in lithotomy position to study the ureter, to study the pelvic calcial system. And according to this situation, I can take my decision. For this example, I found the ureter here very friendly. As you see here, the ureter was dilated. So I went with the scope. I found the stone calcium oxalate dihydrate, for example. And the stone composition in this case is also another factor. If it's expected to be hard stones, PCNL is a better option. If it is expected to be friable stone with medium-sized stone friendly ureter, I proceed to do retrograde intrauterine surgery. In a recent debate in the last American AUA meeting, debate between Gilby Gosto and a famous known big name was PCNL, and the Stephen Ion famous name was Flexi. Most of the endourologists, around three quarters, 77% of endourologists now choose retrograde intrauterine surgery for 2 centimeter stone. It is already won the debate. It differs, sure, because in our localities where the financial issue is important factor, if laser or retrograde intrauterine surgery is costly, PCNL is better. We should choose according to the situation. But now the world is moving toward, as I said, toward more retrograde intrauterine surgery, especially for medium-sized stone. Another interesting situation or debatable situation, also usually we do debates in conferences about upper impacted ureteric stones, to do retrograde intrauterine surgery or to do antegrade puncture or to do laparoscopic. Usually it is a matter of debate according to the surgical preference and availability. Many concern about the bullous edema and the impaction. Many surgeons prefer to do antegrade from the start, but still I prefer to do what's called in retrograde trial. Don't take a preoccupied decision, I'll do puncture. Sometimes you go from down and you find the situation is not difficult, as in these cases, and you can reach the stone and clear it without puncture. The puncture for the antegrade mostly need upper calyceal or mid calyceal puncture and experience. So my policy usually to have a possibility, a retrograde trial. If it's okay, I complete. If it is difficult, I didn't show here some cases I did antegrade or pushback and antegrade. So it depends on the situation. If retrograde is okay, you complete. If it is not okay, you'll be ready to do antegrade puncture and clear the stone. Laparoscopic or open also is a third option in large impacted stones. Now to the more controversial issue, can we start to treat large stones with retrograde intrauterine surgery? Still, as I said, the guidelines is not the best is PCNL, but many centers now moving to start to do retrograde intrauterine surgery for large stones more than 2 centimeters, especially if they have high power lasers or super duster. Financial issue is not a problem. Patient choice, because now with the social media, many patients with counseling, no, I don't want to have a possibility of bleeding. I prefer to do a staged procedure. So it is going toward more cases now to be done in retrograde intrauterine surgery in some localities. For example, this was a pharmacist refusing totally to have a PCNL and came to me or agree for staged flexi, inserted stent and went after that. And clearly the stone was cleared in 2 sessions, 1 stent, and after that I cleared the stone. In these cases, I put a thread with a stent with a thread, not to have a stent for 3rd time, and I pull it after a few days. Another case, the same scenario, branched stone refusing to do PCNL and went for staged procedure and went well with complete clearance with the same techniques. But usually in these cases, I counsel them for PCNL. Only I agree to do retrograde upon their request if they are happy to do staged procedure, not to promise them that retrograde intrauterine surgery is head-to-head in PCNL. We should be clear, it is inferior to PCNL in clearance. It may need multiple procedures. If they agree, we can start to do this. For this case, also the jack stone and patient refusing totally to do pyeloplasty because it was associated with POJ, and done 3 years now in a 2 session, and the follow-up showing some few millimeter residual after 3 years. A lot of examples like this, the same scenario, all clearing in multiple sessions or in 2 sessions mostly in most of the cases. So it is a plan B alternative if the patient is insisted not to have a BCNL or if it has morbidity. Now we move to some technical challenges during retrograde intrarenal surgery. For example, stone relocation. Sometimes it is difficult to fire on a difficult lower cranial angle, and it can damage the scope. So you can still relocate the dormia better if you have a good dormia like the Kuta, or if you have zero tip, and cautiously you can relocate the stone and the fire in a better favorable position like pelvis or like upper calyx. Some trick we do sometimes to save the cost of dormia to do what's called stone relocation using laser fiber. It can be very helpful trick. Just you can dig a tunnel inside the stone, and after that you insert the fiber well inside this tunnel and do deflection, maximum deflection, and withdraw the scope. So insert the fiber well inside this tunnel, do maximum deflection, and pull the scope itself to the renal pelvis. It will go easily in most of the cases. Sometimes if the stone is friable, you couldn't make this hole easily, but with hard stones, you can do it, and you can do what's called laser fiber relocation, but cautiously, not to have the laser fiber broken. You should do it gently and carefully. Another situation, the type of anesthesia during retrograde intrarenal surgery, many prefer to do general anesthesia with controlling the tidal volume and rate not to have respiratory movement that can cause parenchymal bleeding if you fire the parenchyma like this case. Some prefer spinal anesthesia and ask the patient to hold the breath. In this case, the anesthesia was not adjusting the rate and tidal volume, and suddenly when I calling him to adjust it, I fired the mucosa, and you can see the bad luck of having such a bleeder. It went well, but I aborted the procedure with mild hematuria that resolved with no problem. But respiratory movement should be controlled either by general anesthesia with adjusting tidal volume, or by asking the patient to control his breath under spinal anesthesia. Bleeding can be with BCNL is not rare. It can happen either intraoperative bleeding that may affect visibility. So you should be very cautious start of your disintegration, not to do firing to the parenchyma, because simply it can cause bleeding and the vision will be affected, or it can be late post-operative bleeding or subcapsular hematoma. Interesting review published in 2024 about the formation of arterial pseudoaneurysm. We escaped from BCNL not to have pseudoaneurysm. Here with retrograde intrarenal surgery, they had pseudoaneurysm, and reviewing the literature, Traxer and the group from Emirates, they published around 9 cases. And interestingly, many of these cases was under TFL. The theory how pseudoaneurysm happen after retrograde intrarenal surgery may be with increased thermal injury with high power. It is better not to have more than 10 watts or 12 in ureter and not more than 25 in kidney. The heat, especially with TFL, may cause degeneration of the arterial wall and the formation of pseudoaneurysm. This is one theory. Another theory, this may be firing inside the parenchyma. If the vision is not good, maybe firing inside the parenchyma and firing an artery. So the advice is to use low power, especially if you have TFL, not to exceed 25 watts, and usually fire under vision only. Take care of the vision, take care of the laser fiber. You should be under your direct vision, not to have firing of the parenchyma. This may happen. And this is a very interesting review and showing how this case is managed by sclerotherapy after that. Another trick how to use the suction during navigation. I prefer to stop suction during navigation because this will collapse the pelvic calyceal system, will make it difficult, and this may cause transient bleeding. So adjust the power of suction to 100 or 150 to the lowest suction power, especially during navigation, not to have this collapse. After that, after you finish the disintegration, you trap the fragment and use the suction power to retrieve the fragment, what's called assisted vacuum. Assisted vacuum by increasing irrigation and the suction at the end of the procedure to retrieve the fragment like this. So many tricks, sometimes we close the tube of suction and suddenly we open it. This will cause assisted vacuum suction. This can be very helpful also. And the learning curve to sweep the scope gently to adhere the fragment to the tip of the scope and sweep very gently. If we sweep the scope rapidly, the fragment will go back. And you need to go back and retrieve the fragment slowly. And I prefer to do this in a standing position, not to have fatigue in my elbow. I spend 10 to 15 minutes at the end of the procedure, especially I don't have high power laser. I don't have excellent dusting except in friable stone. So this multiple fragment after popcorning, I spend 10, 15 minutes standing and remove this fragment by assisted vacuum suction. Sometimes the fragment is large and stuck in the scope. Simply, you can introduce your laser fiber and just few bursts, not to damage the scope, not to damage the sheath, sorry. And we just dislodge this fragment after firing small bursts of laser disintegration. It will come easily after just small bursts of firing, as in this case. And you can sweep the scope gently and remove the fragment, as in this case. Regarding cystine stone, very interestingly, you should be minded with cystine stone because fortunately many endourologists not minded with issue of metabolic workup. How to see it, how to diagnose it from the first sight. We do every day in urology now, we can diagnose the type of the stone. I have a separate lecture may give after that in a later, after arranging with Dr. Chandra about the metabolic workup of stones.
Sure.
Yes, and I'll give course in the upcoming Arab meeting in Jeddah about this. So if we diagnose cystine stone, we should be careful about the setting because it is a difficult to disintegrate stone. We should raise the power to 2 joules because if we with low power it will not be disintegrated easily. Very easy to look at the classic cystine stone look to diagnose it, and the milky white bubble, as you see, very easy. Once you disintegrate, you will see the bubbles and you will smell the characteristic odor of hydrogen sulfide characteristic, and even my nurses can diagnose cystine with just smelling the odor. And after that, you should put these cases on hydration, very good hydration, on alkalinization, target pH above 7, vitamin B6. And you can check cystine level. If it's okay with this, that's enough. If it is still high, you should put him on thiola or troponin. Unfortunately, it is not available easily, but these cases you can save kidney losses because this disease is a nasty disease, or nasty stones that can destroy kidneys, and we have miserable cases operated more than 20 times without any surgeon told them you have a cystine stone that need to have a strong follow-up. Another challenging situation is to do retrograde intravenous surgery in infected stones. Infected stones, I mean patient presented with emphysematous pyelonephritis, with significant sepsis. This scenario is a challenging scenario. I used to do BCNL previously in these difficult cases to insert nephrostomy tube, do complete drainage, and go after that to do BCNL. But start to do many cases in the last 2 years with fans, with flexible navigation. After drainage, either by BCN nephrostomy or double J, I inserted the fans, and the fans can suck the pus clump and can offer the least intrarenal pressure all through the procedure. This minimizes the sepsis and give a good results, even cases fixed PCN in ICU bed and after that went for Flexi-B and went well. I asked Vinny Gohar to do this study, and we did it multinationally about the efficacy in infected stones, and published previous 2 months in British Journal. I present this lecture in the upcoming SIU in Florence in Italy. So again, we don't have head-to-head studies between BCNL and flexible in such cases, but it is an alternative, especially in comorbid patients where BCNL is still risky. It is an option to offer in these cases. As you see here, how to suck the bus clump easily, and the vision now start to be clear, and clear the stone at the end of the procedure, was leaving a stent to the thread for a few days, and case went well. If you have a TFL that with low peak power that can achieve a true dust less than 250, if you have a high power laser holmium, you can achieve excellent dust. But if you work in a place where just low power holmium 30 watts available, like in my practice, you can change the setting of laser to achieve a rapid disintegration. The famous setting by Traxair to use dusting is low power, 0.2, 0.5, and the fragmentation high power. But what is dusting? Is just sitting? No, dusting is not just sitting, it is a technique. I mean, if you raise the pulse energy to 1 joule or 1.2 joules, and you use the dusting technique of having painting or dancing, don't touch, don't stop, you will achieve excellent disintegration into very fine fragment dust or very fine particles in a short time. I use this technique and I find it very helpful to disintegrate the stone in a shorter time. Don't touch, because if you touch, it will be fragmentation. This is very helpful. You can see how it works well in a short time. This video is a real-time video, not in speed. You can see how it saves time using a low power holmium without TFL, without high power holmium. I published this study in the Arab Journal, and it shows excellent result in 2024 if you try what's called high pulse energy dusting, using the dusting technique with high pulse. Especially it's helpful in hard stones like calcium oxalate monohydrate or cystine stone. It saves time to disintegrate in a short time. So if I have TFL or high power dusting, I can use direct endoscope suction. No need for fans because I achieved a true dust. But if I have low power holmium, I prefer to use fans, simply because this multiple fragment at the end, I can retrieve all the multiple retract and achieve a results comparable to those who have a TFL or high power holmium. Another point or trick is the hard stones. Sometimes you see these light flashes with hard stones. Sometimes it can cause burn back of the fiber or damage of the scope itself. So insert the laser fiber well and be away from the light flashes because it can damage your scope. One of the important trick is the grip. You know the standard grip on the left side of the screen. This is a standard grip of using the flexopetroscope. But this, I prefer to use what's called Bilateral grip. Bilateral grip, as you see in the other image here, I find it more ergonomic and avoid fatigue of my wrist, especially if I do more and more cases. If you look here for the standard grip, after finishing the disintegration, I need to retrieve the fragment. If I use the standard grip, mostly I need to stand all through the procedure to be in rest, because it is difficult to do in sitting. And you can see my wrist now, how this causes fatigue and not ergonomically the best. If I use this standard grip and retrieve the fragment and rotate, a lot of fatigue on my wrist if I use this standard grip. If I use what's called the Bilateral grip, you can see how I'm comfortable no fatigue on my wrist. We presented it in the last meeting of stones in Spain, and we are going to publish this and try to modify the scope to fit the pistol grip, and will be very helpful if you try it. Less fatigue, especially if you do more and more RIRS, will be very comfortable to you than the standard grip. Finally, my final slides will be about the troubleshooting. Troubleshooting simply start from the insertion of fans. Usually don't insert the fans blindly without fluoroscopy, and you should go below the UBG. If you go until you feel resistance, sometimes you puncture the upper pool and do force passage in this case. So insert the sheath cautiously under fluoroscopy below the UBG, and after you go with the scope, slide the sheath over the scope to reach the pelvis, not to have a perforation like this. What's called entrapped sheath. One of the nightmares of using the access sheath is you entrap the sheath. You try to remove the sheath at the end of the procedure, but this is stuck and they cannot be removed. This is one of cases in Cairo University sent to me by Dr. Hisham, one of my friends. It was in a single kidney kid, and after they finished, they couldn't remove the sheath and open the case in a single kidney to open the bladder, and they removed the sheath by open surgery. One of the important tricks is to cut the access sheath from outside the fans, and you will find the nitinol wire. When you pull the nitinol wire, the sheath will collapse and you can remove it. This is an important trick. In literature, many suggest different options. Some suggest to keep the sheath overnight. It will cause passive dilatation and remove it second day. This the situation. This nightmare happened to me last 2 months. The case of bilateral BUG stones, serum creatinine shooting, went for bilateral double G insertion for bilateral uric acid radiolucent UBG stones. He came to me after double G insertion by 1 month. I see by fluoroscopy it was radiolucent stones. I didn't repeat CT, it was a mistake in this case. I went by flexible till the mid-ureter, a little bit I couldn't reach, so I inserted the access sheath. It passed well to the renal pelvis. I didn't find the stone. I tried to pull the sheath. It was entrapped, it didn't come. So I pulled the wire and part of the sheath was out and the part was entrapped inside. This part of the sheath was entrapped inside. I was in trouble and preparing to open the case, but fortunately I went with a small caliber semi-rigid scope. I found the stone between the sheath and the ureteric wall. Hardly I could reach it and disintegrate with laser and remove this part, missed part or entrapped part of the sheath. So the lesson learned from this case: don't insert the access sheath until you until you do retrograde biolography or you go with the semi-rigid scope to make sure there is no stones in the ureter. It was a hard lesson. Fortunately, it went well, but was a nightmare breath-holding case to avoid to do this mistake. The last concern of nightmare is the structure. As Dr. Mohan introduced the lecture, more and more flexi are being done. Young urologists may be not happy with BCNL, will go for the easy learning curve retrograde intravenous surgery. So if we don't stick with rule, we'll find more and more structure and ureteric problem. As in this case, you can see this case was presented by Dr. Omar, my colleague from Monofia. After RIRS, he demonstrated upper ureteric structure like these cases. The second most famous French image after Mona Lisa is Traxer terrifying ureteric injuries. As you said, it was by using 14 French, 12 to 14 French access sheath. Many people are afraid to use access sheath after this image. But now with the small access sheath, we have now 9 French access sheaths with judicious use of the ureteric access sheath with a better quality of fans, more hydrophilic. Rarely we can see the ureteric injury now. And we recently, with the European section group, we published the 1-year results recently in the PGU after fans, and the incidence of stricture was just 1.7. I mean, it is the same like flexible ureteroscope, no added. How to avoid the stricture? It's very important to counsel in my case that this the flexible ureteroscopy could be a staged procedure. I don't promise you it will be a single stage, because in many situations we go for RIRS and we find a tight ureter. Some do dilatation with Teflon and go. I don't prefer this. I prefer to respect the ureter. As you know, ureter don't forgive. We do sins in the kidney with the BCNL, and the kidney forgive us. But as usually we say, the kidney forgive, the ureter doesn't forgive. So better to respect the ureter. If it is tight, put a stent and come back. Don't try to force the sheath vigorously in a tight ureter. I use classic to use a semi-rigid scope, 7.5 French, to judge if the ureter is friendly and can accommodate sheath or not. If I find it friendly, I put sheath. If not, I do backloading. If it is very tight, I do stenting and come back. If you do this as a routine step, after counseling your case, you will not force a sheath in a tight ureter that can cause stricture. Another point to avoid thermal injury, as I said, not to exceed more than 10 watts in the ureter, especially with TFL. Avoid TFL in the ureter, or do it with very low power to avoid this. Finally, my take-home messages. Sorry for being late, long lecture.
No problem,
Careful preoperative planning is the key to success in difficult cases. You should review CT anatomy, and this helps to anticipate difficulties and complications. Difficult anatomy requires patience, flexibility, and adaptation of technique. Staged procedures are often safer than prolonged operative time. Safe surgery first, then complete stone clearance second. Adequate drainage before retrograde intrarenal surgery improves the outcome in infected or obstructed system. The use of suction and maintaining low intrarenal pressure reduce infectious complications. Both the evolving technology and operator experience should improve outcome and decrease complication. Continuous progression in flexible ureteroscopy may increase its clinical applicability and supplant other procedures as the first-line treatment option for urolithiasis. And finally, continuous training and technological advances continue to expand the limits of flexible ureteroscopy. Thank you very much.
Thank you. What a lecture. My God. You have great, crazy fan following. 330 people watching. My
Thank you
God.
very much.
Pin of silence. Lot of fan following, lot of questions. I'll quickly ask you 20 questions. Quick, please. Number one, what is your favorite flexible scope? No conflicts of interest. You are experienced person. You wanted to do a difficult case. Which scope you will pick up?
I used firstly the O2U, the Y scope. I used it for around 2 or 3 years. It is excellent imaging, excellent ergonomics.
What is the scope?
Y scope.
Y scope. It's from which country?
I think it is already now the company Chinese, but originally it was American, but manufactured.
My second question: what laser commonly you use? Holmium or thulium fiber laser?
Holmium. Still, we don't have TFL. We are planning to have it in our university, but still we use the low power Holmium.
Okay. What laser settings is primary laser settings for your stone? Primary. How many joules? How many frequency?
Look, most of the cases referred to me are hard stones, simply because uric acid stones go for medical dissolution. Calcium oxalate dihydrate, friable stones went for shockwave. So most of the cases referred are hard stones, either monohydrate, phosphate, or cystine. So I need to adjust the power. The low power dusting by Traxair doesn't work well with this hard stones. So I use my modified setting to do high pulse energy setting of 1 joule or 1.2 joules and 10 hertz, using the dusting technique as I said.
So for all the audience, I also feel that 1 joule and 1 joule and 10 to 15 hertz is very good. My fourth question, if you have inferior calyceal stone, what size in the preoperative OPD room, you say that, no, I don't want to do RIRS, I will go for PCNL to the patient. You only advise what is the size, 2, 2.5, what centimeters, lower calyx stone. No
More than
IVP
2,
done, no IVP.
yes, more than 2, BCNL is better. And I do what's called double
That's it.
counseling.
That's it. I want that answer. I also feel
Yes.
that now after doing so many complex cases, we are going back after 2 centimeter lower calyx. If it is nicely
Yes.
seen, PCNL is better.
Yes.
In what, if you do, how many cases of your practice are primary RIRS without stent? How many cases you stent out of 100 generally?
Yes, we did a study in our university. We found that around 30 to 35% you cannot do direct. You should do staged. Difficult Indian ureter from Egyptian, from European. We find the different, I think, different figures may be different according to the ethnic population. So in my country, around 30% of ureter are tight. You cannot go directly. And I prefer to do stent in this case.
So which scope you use to calibrate before you say that I will go ahead or I will put stent?
I use semi-rigid Carlstol
6 by
7.5.
7.5? 6 by 7.5?
7, yeah. Yeah.
6 by 7.5.
If it go
And
easily, I
what
can.
is the maximum duration in large stones you keep? You are going very well. You are going very well. You are going very well. 1 hour, 1.5 hour. Where do you stop?
Mostly 1.5 hours if I do fans, if I do continuous suction, if the patient is not comorbid. If the patient is comorbid or of the stone of the stone is not infected stone, if it is infected stones or comorbid, I don't exceed 1 hour. Not comorbid, not infected stone, using fans, this can prolong the operative time. So it needs judgment.
Sometimes when you go into the kidney pushing the stone, some amount of flakes will come. They are not pus. They are stone outer material. It's not pus. If
Yes.
you have any doubt, will you proceed? Pus is a frank yellow color or
Yes.
brown color. But stone flakes, you will continue RIRS or you will stop it.
Yes, I like matrix stones. I have some videos on matrix, but I didn't present. I can cut with laser, do some cuts with laser and do suction. Sometimes it is successful because this can be nidus for stone formation again. I'm trying to do it, but it's difficult. I think BCNL can clear better in this situation with removing this material with forceps, but still feasible. You can cut with laser and suck if you can.
Where do you keep the access sheath if it is not fans? Mid ureter, lower ureter, upper ureter?
If not fans, below the UBG, upper ureter. If with fans, I keep it inside the pelvis.
Yeah, of course.
This is very important because sometimes it withdraw and we miss the advantage of having low intrarenal pressure. Very important to make sure all through the procedure that the sheath is inside the pelvis. It's very important.
A very difficult question. If you have a partial PUJ like picture, do you think by putting the stent and doing RIRS is correct or go for mini pack? Partial PUJ on CT, IVP, nuclear scan, not really kidney is at risk with obstruction, meaty parenchyma, but dilated pelvis, narrowing at the PUJ, especially it happens in ectopic kidney or shoe kidney. You already mentioned. Do you think that stent will help?
In this situation, you don't have evidence about these cases. Like in BCNL, sometimes we see stone casting on a POJ to do pyeloplasty or to remove the stent and have a look. Notice no evidence about this case. Counseling is important. If it is mild, I do stenting for a longer time and do for retrograde intrarenal surgery. If it looks mild, UBG. But if it is very significant, I don't prefer retrograde in this case.
Yeah, last few questions. During the during the surgery, RIRS, can you guess whether the intrarenal pressure is rising by some signs? You will get some flow stopping, small red RBC coming. Any clue on the table you get that pressure is very high?
With doing more and more fans, I didn't face this, because even with irrigation, with high pump irrigation, if you use fans and continuous suction, this will not happen, because this suction will lower the pressure. I am happy. Even I read a paper recently, the best thermal regulation would to have a high flow, high outflow. It will be published. I reviewed this article recently. So it doesn't.
I personally feel if the calyx is moving away, if the background is dark, if
Yes.
the floaters are seen constant, they are not moving, and if the vision is decreasing, in non-fans RIRS, check
Yes.
whether the outflow is there or not. Especially in children, it happens within 1 minute or 2 minutes after injecting 10 ml. It's a very dangerous situation, so one must
I
avoid.
know you have a vast experience in children. I don't have the same experience. I did few cases. It is very critical, as you said, in using in children, in tight ureter, using this, not fans, not continuous. You should be very cautious. And I think the automated suction will be very helpful for these scenarios.
100%.
But
Last question. When the access sheath is not coming out after repeated attempts at the end of the surgery, what are the maneuvers you do to remove it? It strucks sometimes. You don't feel comfortable in pulling out. Do you have any tips and tricks?
yeah, sometimes, like semi-rigid scope, we try to pull and move from side to side very gently. We do this, some inject some hot water, some inject gel. These are a lot of tricks, but gently it can happen. The other trick I show it to cut the nitinol wire. This will collapse the sheath. Some do overnight. Fortunately, it didn't happen to me. Last case, just a part of the sheath, I show it to you. But the best treatment is prevention. The best treatment is prevention. I mean, not to force a tight sheath in a tight ureter. Calibrate first with semi-rigid, and you should do staged procedure in tight ureter. This is very important.
I have one trick, if with your permission. You insert the obturator, you pass the guide wire. Guide wire acts as the opposite force. Obturator acts as the togetherness. And then, as you said, front back, millimeter, front back for 10 minutes. If you do with water pouring at the tip of the penis, sometimes it comes out, but some people have waited till next day, and that's fine. Naturally, ureter gets dilated and it will come out. So, Professor, it's really amazing. One of the largest attended recent past pure urology program. I really salute you and your commitment to teaching, your collection. You are very, I'm visualizing how much passion you have to go all these recordings, all the varieties of this program today will be lasting forever in YouTube with so much coverage, and it's a good lesson to the youngsters you have given. I'm very thankful to you. I'm really thankful to you.
Thank you very much, Dr.
We'll conclude
appreciating.
Very good.
Thank you.
Thank you very much. Yeah.
Any more questions from audience?
No, we'll conclude, sir.